I think we will start. So I'm joined here by my colleague, Dr. Ajay Sharma, who's my former fellow from STPGI and now the head of the Department of Surgical Gastroenterology. He also has special interest in pancreaticoduodenectomy. So I will question. And Dr. Sitaram, the format is very informal. During the presentation, you can interrupt Neha and make a comment or ask her some question also.
Sure.
Neha, please start.
Thank you, sir. Good morning, respected teachers and dear friends. Today's topic is on pancreaticoduodenectomy in context of pancreatic ductal adenomyosis. Sir, with the PDAC, we know that the disease generally has a late presentation and only about 15 to 20% of patients are potential candidates for the surgery. The pancreaticoduodenectomy that we do, it is a complex and high-risk surgical procedure, and it has best outcome and lowest mortality in high volume centers. We'll discuss about it later. The median operative time is 5 to 5.5 hours with median blood loss of less than 4% body volume. The acceptable mortality world over is less than 4% as of now, with a morbidity of 20 to 30%, which has remained relatively unchanged. So in today's presentation, we would discuss about some history of pancreaticoduodenectomy, the indications for the procedure, the presentation as to how the patient presents with respect to PDAC, the diagnosis and staging, the procedure itself, the controversies or the with respect to the procedure, the complications of the procedure, then how to do post-operative care of the operated patient, patient fit to discharge, and how does pancreaticoduodenectomy assesses the institutional efficacy. So the history dates. Yes, sir.
Can I request you to go on to the next part of your presentation? Leave history out.
Yes.
Indications. Go to indications.
Yeah, Neha, please concentrate on the operative surgery part.
Yes.
Yes. And everybody, please mute yourself. Everyone.
So the indications for the procedure is most commonly it is the resectable carcinoma head of the pancreas, any periampullary cancers, non-periampullary duodenal cancers, neuroendocrine tumors of the head of pancreas, or cystic pancreatic neoplasms, sometimes chronic pancreatitis with suspected head mass localized to the head, or maybe undiagnosed pancreatic head mass. It is sometimes also done as part of multivesical resection to achieve R0 resection in case of CAGB, cholangiocarcinoma, CA stomach, or CA colon, and in complex pancreatic disease in emergency conditions. But there are some contraindications, that is the distant metastasis, if there is proven distant metastasis, if distant lymph node involvement, that is the celiac group, para-aortic or aortocaval groups, if there is encasement of arteries, SMA, CHA, hepatic artery proper or celiac axis, and poor general condition of the patient. So the patients in for pancreatic cancer generally have different presentations. Small tumors with early disease, patients are generally asymptomatic. In periampullary lesions, patient can have painless obstructive jaundice, pruritus, clay-colored stools, or dark-colored urine. Weight loss, fatigue is a common feature with vomiting present in cases of gastric outlet obstruction. There can be change in character of pain, which was previously there in patients with chronic pancreatitis with new onset diabetes or worsening endocrine status. And in rare patients, they can present with acute pancreatitis, upper GI bleed, or cholangitis per se. So patient who is coming like this and we have to plan for the surgery, the baseline preoperative workup involves any previous history for any surgical or medical illness in the past that may affect the current status. The respiratory, cardiac, renal, and cerebrovascular system workup. Smoking cessation is a must if it is preferred to have around 4 weeks of smoking cessation, and blood sugar monitoring and control. The ASA grading of a patient is a must to be done because ASA grades more than 2 have a deleterious effect and increased chances of morbidity in patients undergoing this procedure. Performance status of the patient needs to be worked up to check for functional capacity workup by ECOG scoring, and biochemical tests like baseline workup for CBC, RFT, LFT, INR, ECG, X-ray chest, and CA19-9 levels for prognostic workup is important. As this disease is a hypercoagulable state, So anticoagulation status, we have to monitor. Patients who are previously on some anticoagulants like clopidogrel or high dose aspirin need stopping, but low dose aspirin can continue in such patients. So how to select a patient for pancreaticoduodenectomy? We have to look for general fitness of the patient. General fitness of the patient can be by the ECOG performance score, where ECOG performance score of 1-2 is good for us. Breath holding time, if it is around more than 24-25 per minute, that is very good for us. The MET score of more than 4, that is the patient can travel more than 2 flights of stairs at a time, is a good indicator of good health and decreased associated morbidity post-procedure. And ASA grading, as we have discussed, ASA grading of more than 2 is helps in decreasing the post-op morbidity. This is apart from the previous things that we have discussed.
Neha.
The other thing that is more important is,
Neha?
yes, sir. Yes, sir.
Can I interrupt you?
Yes,
If
sir.
you were to post a patient for pancreaticoduodenectomy
Yes,
in
sir.
your institution, before you post the patient, you have to ask yourself 2 questions. First question is, does my patient need an operation?
Yes, sir.
The answer to that question is yes. Then the second question is he fit to undergo the operation?
Yes, sir.
And the answer to that question is also yes. Then you post the patient for the operation.
Yes, sir.
Okay. Now, why is the second question very important, particularly with pancreaticoduodenectomy?
Sir, it is a very morbid procedure,
Yes.
very
So,
complex surgery. The incision is high up in the abdomen. So post-operatively, again, because it is a morbid procedure, patient post-operatively should be nutritionally fit, should be good with respect to other systems, because the patient needs to rehabilitate. Patient also has multiple anastomosis which needs healing. So his nutritional fitness and his general fitness is extremely important if we want adequate healing of the patient and early discharge.
yes. So the patient should not only be able to withstand the operation, he should also be able to withstand the complications of the operation, which in your own words is 1 in 3.
Yes, sir.
So 1/3 of our patients will have problems, probably more, and they have to survive the operation. Okay, so that is important to understand. Okay, please go ahead to nutritional fitness.
Yes. The other most important part is nutritional fitness for the patient, because most of these patients, when come to us, they are in late stages, or because of the condition itself, they are cachexic or sarcopenic. So we have to have a good idea about their nutritional fitness. So it can be by clinical examination, because if the patient has pallor, what is the weight of the patient, what is the BMI of the patient, if the patient has any dependent edema, if there is any ascites, if muscle wasting is there, or there is loss of subcutaneous fat. Skin fold thickness and mid-arm circumference measurement are some very good indirect measures for body fat stores, which can be done on the OPD basis. Biochemical markers also help us in knowing the nutritional fitness in the form of serum albumin, pre-albumin, or transthyretin levels. And subjective global assessment scoring is again something that we can do at bedside to decide if the patient is nutritionally fit. So what is the diagnosis? Yes, sir.
Previous slide.
Yes,
In
sir.
all of these, what would you say is the most important?
Sir, the most important, I would say, is subjective global assessment score, sir, because it incorporates all the other things which are there, sir.
Very good, very good. There's very good evidence to say that subjective global assessment is a very good marker for outcomes after major operations, especially in cancer. Okay, so there's good evidence. It is very easy to do. It takes only about 2 or 3 minutes, about 7 or 8 features in history, 2 or 3 things in examination, and it is very subjective, very global, but gives a very good assessment. Whereas the others are all, some of them are all technology driven, some of them are not used at all in clinical practice, like trifold skin fold thickness, we don't do. Mid-arm circumference, I've never seen it being done. But subjective global assessment is very good, and I think you should concentrate a lot on that in your practice. Okay, please go ahead.
Yes. So selecting the patient is not only just nutritional and general fitness. We have to then diagnose the patient also as to if the patient actually needs the surgery. So what do we have with us as a diagnostic armamentarium? Most important is, of course, multi-detector CT with pancreatic protocol that the patient needs to undergo. Then there are centers which use MRI. MRI per se is superior imaging to CT scan, but it is not widely available. And in our practice, we are much more comfortable with the CT scan. We generally go ahead with the CT scan.
Then, these are very, very general points. You can skip them. Come specifically to PD.
Okay. So a patient who is presenting, if there is clinical suspicion of pancreatic cancer, patient needs to undergo a pancreatic protocol CT or MRI and a multidisciplinary team review. If we find a mass in the pancreas on imaging, then the patient needs a metastatic disease workup. If the metastatic disease is there, then biopsy confirmation is needed for the metastatic site. And if there is no metastatic disease, then we can go ahead with EUS and FNA of the mass which is there to confirm the disease. But if there is no mass in the pancreas on imaging, then metastatic disease workup is again required. If you find a metastatic disease, then go ahead with a biopsy confirmation. If no metastatic disease, then we have to still consider EUS with FNA to confirm or refute the diagnosis of pancreatic cancer. So the initial imaging, generally when the patient comes to OPD, most of the patients with those vague symptoms go for an abdominal ultrasound. It tells us about the biliary tract dilatation, pancreatic lesions which are more than 3 centimeters are visible, any ascites is there, or gross metastasis can be seen. Pancreatic protocol CT abdomen, about the protocol itself, which I'll discuss later again. It has high sensitivity of around 89% and a specificity of 90%. It shows ill-defined hypoattenuating mass within the pancreas with pancreatic duct cutoff and CBD dilatation. And it can also show us the relationship of the mass to other structures and the related vascular anatomy, all of which is extremely important to plan the surgery. EUS FNA, when we come, it is better than CT and MRI for lesions which are less than 2 centimeters of size. It has a sensitivity of 94% compared with 69% for CT and 83% for MRI. And the diagnostic accuracy of EUS when there is no mass on CT scan is about 92%. There was a large meta-analysis done which showed a pooled sensitivity of more than 85 to 92% and specificity of 94 to 100% in the diagnosis of pancreatic cancer. And with EUS, patients can undergo either fine needle aspiration cytology or fine needle biopsy, both of which generally there is no significant difference with respect to the yield that they give. Patients generally also undergo CA19-9 levels. It is a validated and clinically useful marker, which is generally not seen in patients with Lewis antigen negative patients. The preoperative levels correlate with AJCC staging and the resectability of the patients, and it is not a diagnostic marker but a prognostic and predictive. So our CA19-9 levels of more than 130 units per ml is a significant predictor of finding radiographically occult unresectable disease. So how to stage up the patient? We have diagnosed that the patient has pancreatic carcinoma. So then how to stage the patient? We go ahead with an MDCT pancreatic adenocarcinoma protocol CT, which is a helical CT with thinnest possible films, with mostly a neutral contrast or may require a positive with iodine containing contrast. The injection is done at a rate of 3 to 5 ml per second, and 2 images are obtained. One is a pancreatic parenchymal phase, which is at 40 to 50 seconds, and the next is a portal venous phase at 65 to 70 seconds. If the tumor lights up in the earlier phase, it is more likely to be a neuroendocrine tumor, and the portal venous phase is the workhorse of this CT scan, and tumors in this phase show the hypoattenuation and the other features that we have just discussed about. So this is the pancreatic protocol which is being followed. But how to define the resectability? The resectability not only depends on the anatomical characters that we have seen on a CT scan, but they also depend on the biological character of the disease process and also on the status of the patient. So in 2016, the International Association of Pancreatology gave the ABC classification, where A stands for anatomical workup, where we know that the tumor contact, again, it is like the anatomical workup again depends on its the approximation of the tumor with the arterial and the venous anatomy nearby. So a tumor contact with SMA or celiac axis of less than 180 degree without showing stenosis or deformity, or a tumor contact with common hepatic artery without showing tumor contact with hepatic artery proper or celiac axis, and tumor contact with SMV-PV, including bilateral narrowing or occlusion without extending beyond the inferior border of the duodenum. These can be resected. But biologically, if a disease is potentially resectable, when the disease, we have seen that it is resectable as per the anatomical criteria, but the clinical findings are suspicious of distant metastasis or regional lymph node metastasis, which is diagnosed by biopsy or PET-CT. So here we have to look for CA19-9 levels, because as we have seen that levels which are higher give us more idea towards radiologically occult mix. So for this, the cutoff generally taken is CA19-9 levels of more than 500 units per ml may have higher chances of biological unresectability. And if the patient has an ECOG performance score of 2 or more, then the patient is conditionally inappropriate to undergo the surgery. Therefore, even if the patient is anatomically fit, but is biologically and conditionally unfit, we might have to rethink our decision of resection. So based on the above findings, the patient can be divided into a resectable, where patient can go for an upfront surgery, or a borderline resectable disease, where patient requires neoadjuvant chemotherapy, or locally advanced disease, where the patient requires neoadjuvant and adjuvant. Generally, locally advanced disease, we go for a palliative care. So this was for the local disease, and for distant metastasis, we generally go for CT chest and PET-CT, where NCCN and the European and the ESMO guidelines do not recommend routine use of PET-CT for staging. But staging laparoscopy, it has shown that 1/3 of patients who were thought to be resectable earlier are found unresectable after staging laparoscopy. So it is proven that staging laparoscopy is to be done, but in selective cases. As of now, there is an ongoing trial, the SLING trial that is going on, which is incorporating staging laparoscopy with contrast enhanced intraoperative ultrasound and ICG staining to further enhance the retrieval of any positivity which is there, which might be missed on simple staging laparoscopy.
Neha, can I stop you there?
Yes, sir, please.
Neha, I am currently in a hospital where endoscopic ultrasound scan is not available.
Yes, sir.
Wide viewing gastroscopy is not available. So in a patient who has distal biliary obstruction,
Yes, sir.
on ultrasound scan and who presents with features of obstructive jaundice, what are my options?
Sir, we can go ahead with an MRCP if it is distal biliary obstruction. And
MRI is not available. MRI
Yes.
is not available. MRI is not available. On ultrasound scan, it is distal biliary obstruction.
Sir, do we have endoscopy available?
Gastroscopy, forward viewing gastroscopy is available.
Sir, is there, but no side viewing. So ERCP would be a difficulty if there is no side viewing available.
Even side viewing gastroscopy not available. So ERCP out of the question.
So sir, if on ultrasound there is distal obstruction and we see that there is the biliary radicals are dilated, so we can go ahead with a PTC, sir, percutaneous transhepatic catheterization of one of the ducts, and then we can go ahead with a dye study, sir, for the same fluoroscopic guided to see what is the status of the biliary tree, where is the obstruction, sir, and then if that is also not visible, then otherwise, sir, we have a CT scan, so we can just go ahead straight away with an MDCT, sir. We have a CT scan.
Okay, so MDCT, if MDCT shows a mass lesion in the distal end of the common bile duct or in the pancreas obstructing the common bile duct, is a biopsy always necessary? My understanding,
biopsy is not always necessary, sir.
Not necessary. A
No,
fine needle
that I've
aspiration
discussed later,
cytology
sir.
is not necessary.
Yes, sir. Biopsy is not always necessary. If we have any suspicion, if it is a suspicious lesion or if it is a confirmed lesion, we generally don't need a biopsy if it is resectable. Only if it is not resectable, we are planning some neoadjuvant therapy or we are planning palliative therapy, then we need, or we are still in doubt of the diagnosis, then we need to go ahead with the biopsy.
Okay. So supposing on CT there is no mass lesion, seen obstructing the distal common bile duct and the pancreatic duct, then what options do I have?
But there is still dilatation, sir.
Yes, there is dilatation, there is obstructive jaundice.
So then again, sir, I can go ahead with a fluoroscopic study, sir, to delineate the biliary tree and the pancreatic duct, sir. If there is a double duct sign which I can see, then maybe I can be still a bit more towards that there is a head of pancreas mass, sir.
So now we come to a situation where two possible situations. One where there is double duct sign, one where there is no double duct sign. No
Sir,
mass lesion,
yes, sir.
obstructive jaundice, distal common bile duct obstruction, one where there is double duct sign, one when there is no double duct sign. Isn't
Sir,
it?
but again, if I don't have anything else which is available with me, then I would straight away like to go for a diagnostic laparoscopy, maybe take a biopsy of any nodes which are available, or if then I can find something gross there, sir.
Okay.
So if I may add, most groups would follow, and this is the answer probably most examiners would expect from you in the exam, is that when you have a suspicion of a periampullary or pancreatic cancer, you make whatever possible attempts you have to get a tissue diagnosis, but it is not mandatory.
Yes.
You can go ahead with resection even without a tissue diagnosis, provided you have ruled out other causes. So what Dr. Sitaram was again and again asking you, when you have a double duct sign, what is double duct sign? That both CBD and pancreatic duct are dilated, which means that the obstruction is either in the ampulla or at the papilla. That is why it is causing dilatation of both ducts. So in that situation, even if you cannot get a tissue diagnosis based on the radiological imaging suspicion alone, you can go ahead with a resection. On the other hand, what he was saying, that if the double duct sign is not there, which means that the PD is not dilated, only the CBD is dilated. So it could still be a lower end cholangiocarcinoma, which is not involving the ampulla, and therefore it is not causing the pancreatic duct dilatation. But you have to keep the possibility of a stone in that situation. So you take the indirect evidence, whether there are stones in the gallbladder, whether there is history of pain, whether there is intermittent episodes of pain or jaundice, which are more in favor of stone disease. In that situation, probably an MR or an US would be more helpful. So that is what you have to rule out. But in such cases where you go ahead with the resection without a tissue diagnosis, counseling and proper written informed consent explaining to the patient that there is a small possibility that finally it may turn out to be non-malignant is there. Now, if the patient survives without any major complications, it is good news. But unfortunately, if there is a mishap, there is a mortality, then you may be questioned by the other relatives that why did you go ahead with the resection? So that is the importance of tissue diagnosis before you do a pancreaticoduodenectomy.
Should I go ahead, sir?
Yes, please.
Yes. So the staging laparoscopy is generally used as a selective approach. It is used for tumors of the body or tail of the pancreas with potentially resectable disease by CT scan, or tumors which are large, more than 3 centimeters. If high quality imaging is suggestive of occult metastatic disease, that is some thickening here and there, but we are not completely sure that it is metastasis, or initial high CA19-9 levels. So in these cases, staging laparoscopy should be done. The other staging that we have is the TNM staging, but TNM staging per se is not a preoperative staging. It is it is more of a pathological staging. So I would just like to go ahead. So let's talking about the tissue diagnosis. It is not required for resectable and suspicious solid lesions. Methods most commonly used are the EUS, FNB, and FNAC. Or if we are not sure, then intraoperatively also we can go ahead with a transduodenal FNA or true-cut biopsy. Ultrasound or CT guided percutaneous FNA is not recommended unless the lesion is unresectable. So is it necessary? It is only necessary in some special conditions where the disease is unresectable and it is planned for non-surgical treatment. It is important to make the diagnosis before neoadjuvant therapy for borderline resectable pancreatic cancer. If there is suspicion of autoimmune pancreatitis, or we want to, if it is a metastatic disease and we want to confirm the. So now that we have staged and selected our patient for pancreaticoduodenectomy, how to prepare the patient? There are multiple things. One is preoperative biliary drainage. Preoperative biliary drainage generally is done with 10 French elastic stent we do, but NCCN guidelines have now said that short length SEMS can also be used. So it is done mainly in patients with uncontrolled cholangitis.
Neha,
Where there is, yes, sir.
I want to interrupt you. Tell me 5 things you will do pre-operatively in a patient who has obstructive jaundice going up for an operation. 5
Sir,
things.
5 things with obstructive jaundice.
Pre-operative preparation.
Yes, sir. Pre-operative preparation for a patient with obstructive jaundice. First, if the patient has uncontrolled cholangitis, sir, I would like to stent the patient. I would like to bring the control the cholangitis with antibiotics.
Did you, Neha, sorry, did you listen to the question carefully?
Yes, sir. 5 things.
Sitaram asked you 5 things which you do to prepare a patient with obstructive jaundice. Now we are not talking of pancreaticoduodenectomy. We are talking of preparation. So start with what is most commonly done. Don't start with uncontrolled cholangitis.
Yes, sir. First, I would like to check the LFTs of the patient. I would like to see the INR of the patient. If the patient has any coagulopathy, we would like to control the coagulopathy of the patient, sir. The platelet count.
Neha, preparation of the patient, interventions you will.
Everyone, please mute yourself. We have a lot of background noise today. We are not the host, so I can't mute everyone. Please mute yourself. Somebody's mic is on. Yeah, Neha, please carry on.
Sir, the interventions in a patient with obstructive jaundice would be stenting. It would be management of coagulopathy, sir, again by preoperative. And
what do you mean by management of coagulopathy?
Yes, sir. If the patient has coagulopathy, sir, generally by cholestasis, the patient may have coagulopathy.
What do you mean by management of coagulopathy?
Sir, we would stent, we would give vitamin K if it is required. We'll start with vitamin K and also
how will you give vitamin K?
Yes, sir.
How will you give vitamin K?
Sir, vitamin K can be given IV, sir. When I'm IV for 3 days, sir.
Okay. After that, what will you do?
Sir, platelet count generally.
No. Vitamin K. You give vitamin K, and then what do you do after that?
So we monitor for 3 days. Sir.
You give for 3 days. Okay. Then after that, what do you do? Supposing the INR is 3 before the patient is given vitamin K.
I would like to then take the patient up, would give fresh frozen plasma or to manage the patient for this.
No, not a good answer. Supposing you give vitamin K to a patient whose INR is 3, you will have to recheck the INR after your 2 or 3 doses.
Yes, sir.
If that patient's INR doesn't normalize, what will you do?
I'm not exactly sure.
No, that patient is a very dangerous patient because it is very likely that he or she has intrinsic liver disease along with obstructive jaundice. So don't say I will use fresh frozen plasma and continue. Are you clear?
Yes, sir.
So the first answer I've got from you is that you will give parenteral vitamin K. What are the other pre-operative preparatory interventions you will do in a patient with obstructive jaundice who is going up for an operation?
Sir, if the bilirubin is quite high, I would like to bring it down by stenting the patient, sir.
That is debatable. So we'll hold that for the time being. What else?
Mention things which you would do in all patients with obstructive
Yes, sir.
jaundice. Then come
Sir,
to
I
those
would like to give
interventions.
some, the patient, I would like to give nutritional supplementation to the patient, sir, because the patient would have fat soluble vitamin deficiency.
Very good.
Yes, sir. So I
Very
would
good.
like to give
Very good.
nutritional supplementation to the patient.
Nutritional supplementation. Okay, that is second. What is the third? What about hydration?
Yes, sir. We have to hydrate the patient.
You have to hydrate the patient. Okay.
Yes, sir.
What else? You're operating on the upper abdomen.
Yes, sir. So respiratory fitness we have to monitor for the patients, sir. These patients
Intervention. What intervention will you do pre-operatively?
I'm not able to.
Not sure. What about incentive spirometry?
Yes, sir. Yes, sir.
Neha, nothing is understood in the exam. We know that you know it, but you don't get marks unless you say it.
Yes, sir. Sorry.
So everything has to be said.
Yes,
The
sir.
examiner can read into your mind, but you have to say it.
Yes. Incentive spirometry, sir, to monitor the or to increase the respiratory fitness of the patient, sir.
Okay. What are the types of incentive spirometer you know of?
Sir, there is this bedside incentive spirometer where.
Both are bedside only.
Yes, sir. We have seen just one type, sir.
See, what type have you seen?
Sir, it's the one with the balloons that we use where you inhale and exhale with pressure so as to increase the, so as to get the balls up.
There are 3 balls there. Tri-ball.
Yes,
Tri-ball.
three ball one that we use.
Okay. There's another one called coach type incentive spirometer. Which is better?
I'm not sure, sir.
Not sure. Okay. Coach is much better because it helps you to sustain, helps the patient to sustain inspiration and maintain that over a period of time at the required level. Okay. Tri-ball gives a visual stimulus for the patient to perform, but coach is probably much more effective than tri-ball. Okay. So any other intervention?
One, two, three, four.
You must have read about prehabilitation.
Yes, sir. I have mentioned it. Yes, sir.
Yes. So what about prehabilitation? What will you tell the patient to do?
Sir, prehabilitation would be a general exercise that the patient needs to do, sir.
No, I'm not asking you for a textbook definition. I'm asking you what instruction will you give the patient?
I would ask the patient to take some generous walk in the ward, sir, daily.
What is a
And
simple,
some
very
exercises,
effective
maybe
exercise
jumping
for the
jacks or
patient
something.
to do?
If the patient is able to do them, I would like to ask him to.
Okay.
Do.
All
students, please note, please stop speaking as soon as the examiner starts speaking. That's a basic dictum. Stop in the midway of your sentence. As soon as the examiner starts speaking, stop. Yes.
So what simple exercise can you ask the patient to do, Neha?
Sir, the patient can just do simple sit-ups, or the patient can just take walks in the wards.
Okay, so my recommendation for my patients is that staircase is a very good exercise. Go up and down the staircase, one flight of stairs. Go up and down. Up and down is considered as one, and they try to do as many of these repetitions as possible. Okay.
Oops.
Right. Shall we move on? Go on to preoperative biliary drainage.
So it is indicated in patients with uncontrolled cholangitis or patients who are in need for neoadjuvant therapy for disease. In patients with very high serum bilirubin, where the cutoff level is as per institution preference. And again, if the patient requires time for prehabilitation, which we go for 4 weeks, if the patient can have that much time, then we can go ahead with the preoperative biliary drainage for the same. If the patient has severe pruritus or uncorrected coagulopathy and renal dysfunction due to cholestasis. So if...
What's missing in your list, Neha? if nutritional rehabilitation is not achieved without stenting, you may have to stent the patient. Okay, please go ahead.
And also you have to remember that in our setup, sometimes there may be social reasons. Patient needs time to arrange money, to arrange blood, has some social activity at home, wants to defer surgery for some time. So if the bilirubin level is very high, some groups may want to stent while the patient is waiting rather than not. So you can add that at the end. Yes, please carry on.
If preoperative biliary drainage is done, it has been shown that there may be more infective complications, that is SSI and intra-abdominal sepsis. But if it is not done, then bleeding complications and there is increased risk of renal and hepatic dysfunction. If PBD is done for cholangitis, then we have to wait for 7 to 14 days after the cholangitis is controlled. And generally some Western centers prefer that if high serum bilirubin is there, then they generally wait for bilirubin of less than 5 milligram per deciliter, but it is an institutional preference. So what is the role of prehabilitation before the surgery? The fundamental principle of prehabilitation is preoperative preconditioning of the patient enables the patient to better withstand the postoperative stress response. So it is any intervention which is aimed at improving the patient's health and lifestyle prior to definitive therapy, which is usually surgery. So the components are generally exercise and preconditioning, nutritional support, and psychological well-being of the patient. So as per ERA's protocol, preoperative preparation, we require the patient to have a thorough counseling for the procedure and the disease. If possible, we have to get at least 4 weeks of smoking cessation. Preoperative nutritional intervention is required in patients with severe weight loss, that is those with BMI of less than 18.5 kg per meter square, or with ESPEN guidelines state that if serum albumin is less than 3 grams per deciliter, or if the surgery needs to be delayed for more than 2 weeks, we have to prescribe supplementary nutrition. So preoperative fasting is for 6 hours for solid and 2 hours for liquids, where carbohydrate loading is generally recommended by ERAs. Bowel preparation is not recommended by ERAs. We have to avoid any
Neha, we have lost you.
Yeah, I think we've lost connection with them. But her slides are still there. So
hospital database.
yes.
Generally, if it is based on the previous SSI, if it is based on previous SSI culture of the hospital, then there are lower risk of SSI in the newer cases. But longer duration of antibiotics are given in patients with back to B. And in these patients, there is lower wound infection.
Neha.
Yes, sir.
So this is the 5th one that I was talking about. Perioperative antibiotics is the 5th intervention in a patient with obstructive jaundice.
Okay, sir. Got it, sir.
Okay.
So moving ahead to the operative procedure, the patient receives anesthesia. Thoracic epidural anesthesia is generally preferred for a better post-operative pain control and general anesthesia. IV antibiotics are given within 60 minutes before the skin incision. Patient is placed in supine position and all bony prominences are well padded. Staging laparoscopy is done as per the indication. The key steps of the surgery are first a Cattell-Brash maneuver to expose the SMV, then the extended Cocker maneuver.
Neha.
Then we have to go ahead with a portal dissection.
Neha.
Yes, sir.
How relevant is staging laparoscopy in a patient with distal biliary obstruction caused by a cancer?
So staging laparoscopy is to be done.
Because in a patient with distal biliary obstruction from cancer, patient is on the operating table because he is reasonably fit.
Yes, sir.
And if you open and you find, let us say, a small liver met, he is inoperable, but you can still offer him a biliary enteric and a gastroenteric bypass.
Yes, sir.
Isn't it?
Yes, sir.
So staging laparoscopy becomes relevant if you are capable of doing a biliary enteric and a gastroenteric bypass laparoscopically. Am I right?
Yes, sir.
Are you capable of doing laparoscopic biliary enteric bypass and gastroenteric bypass?
Not here, sir. Not here, sir.
No, you are not capable. So you say, in my practice, I'm not capable of doing this. So I will not do a staging laparoscopy, because even if I open and find inoperable disease, I can offer the patient a palliative bypass.
Got it, sir.
Only difference of opinion would be that if one believes in non-surgical bypasses, biliary as well as gastroduodenal, then probably staging laparoscopy would be useful, because most groups would now probably prefer a non-surgical bypass in unresectable cases.
Okay. Should I continue, sir?
Yeah, I think Ajay wants to say something. Yes, Ajay.
Yeah, I think it is a good presentation. Some important things which you have mentioned. I think my sound is echoing. So okay, I'll just come on the other screen. Just for a second.
Come here.
Neha,
Yes, sir.
as a protocol, I think what Dr. Kapoor is emphasizing is that a diagnostic laparoscopy is useful in almost all the patients with head of pancreas malignancy, but not in the patients who are having a cholangiocarcinoma or a small tumor, because in this group of patients, they will be usually they don't have a dissemination which is not picked up early. And if the patient has an obstructive disease, the intervention is always in the form of a non-surgical intervention. That is, if you want to do a biliary stenting or a duodenal stenting. Other thing, you just now mentioned in one of your initial slides that the regional lymph nodes is a non-resectable disease.
More than regional, sir. I said a celiac axis and para-aortic group of lymph nodes.
Yeah, so there are groups which are still going ahead with the regional lymph node clearance in spite of that. And if that is positive, then it is considered to be a disseminated disease.
Yes.
There is now a present trial which is going on with the solitary liver metastasis that should be go ahead with resection in this group or not. So that is again an area of discussion into it. There's some more points which I think if since we are going ahead on the same point right now, that a CA99 versus a staging laparoscopy, you said. A higher level of CA99 indicates a staging laparoscopy. That was one of your statements in between.
Yes, sir. I said that a higher level of CA19-9 increases chances of radiologically occult mets. So there maybe we can plan that if we go for a staging laparoscopy, we'll be able to pick up more mets.
I think Dr. Sitaram, what is your say on that?
I think in malignant distal biliary obstruction, I am not in favor of staging laparoscopy, because I feel we have good option, a fallback option that we can offer the patient. Even today, I believe that an operative bypass in a fit patient is better than a non-operative bypass, because non-operative bypass involves repeated interventions, is eventually works out costlier and is not as effective. However, the morbidity and mortality of an operative bypass is more than a non-operative bypass. I concede that. But in the patients in whom it is successful, and in the vast majority of patients it is successful, it is a more effective form of palliation than a non-operative bypass. The non-operative bypass requires technical expertise. It requires a lot of technology, some things as well.
Somebody's microphone is on. We are not the host today, so I can't mute anyone. Everyone, please mute yourself.
and in small centers, which in the majority of our country, in most centers in our country, these things will not be available. Like EUS will not be available in many, many centers in our country. So I feel that staging laparoscopy for the most part of our country is not very relevant in malignant distal biliary obstruction in a fit patient.
So what we are trying to impress upon you is that if your philosophy is to do a surgical bypass, then staging laparoscopy is of no use, because even if you find metastasis, you are going to do a surgical bypass, isn't it? But if your philosophy is not to do a surgical bypass and you have the facility and the expertise for non-surgical bypass, then definitely staging laparoscopy helps, because you are avoiding an unnecessary laparotomy. Also, as Dr. Sitaram added, you have to see whether you have skills for laparoscopic bypass procedures, because then anyway it becomes therapeutic. So one has to differentiate between diagnostic laparoscopy, staging laparoscopy, and therapeutic laparoscopy. Okay. Again, at this level, at MCH level, as I keep on saying again and again and again, there will not be one correct answer to most of the questions. There will be options. What we expect from you is to discuss those options, the pros and cons, and then choose one and justify why you are choosing it. Just as Dr. Sitaram justified his philosophy of not doing a staging laparoscopy, and he gave the reason for that. Yes, Ajay.
Yeah, we can have any reason, but only thing is how strong we are on what we are saying. Actually, if we see my generation, we have passed from what Dr. Sitaraman is saying right now. That is what we used to do around 10 years back. And now we do almost always a diagnostic lab and refer to the gastromedicine. So we have been into both the stages. And since you are in the newer stage right now, you have all the facilities available at Gangaram Hospital. So you would say that I would do a diagnostic lab. Some more point which you have mentioned recently, pre-operative biliary drainage. So
Yes.
say on jaundice, what is your say on jaundice? Cholangitis we know, denal surgery we know, but level of jaundice.
Sir, level of jaundice is a very institutional preference, sir. Here we prefer to go up to the level of, if the patient has a level of around 10 to 13 also, we can go ahead with the procedure, sir, here. But then it is a very institutional preference. West, they generally prefer to go for a lower level of around 5 milligram per deciliter, but here generally we follow a higher level, sir.
And what is, I would like to have Dr. Sitaraman sir's opinion on that, because I'll come with something different now.
Yes. We have not had a bilirubin cut off to decide on pancreaticoduodenectomy. We have operated on patients with 20 milligrams, 25 milligrams. We have not had any difference in outcomes at Vellore. The magic of this 15 milligrams cutoff came from the Dutch trial, where they randomized 2 groups of patients, and the explanation that they gave was the majority of their patients fell below 15 milligrams. So that from there, this 15 milligram magic number has come up. We don't believe in this. Thank you.
That is, Neha, actually what I wanted to emphasize, that actually bilirubin level in today's scenario with a gradually increasing trend has no relevance now. There is, if you see the literature, there has been a quite significant number of PDs being done with a Whipple, with a bilirubin of 40. And
Yes.
patients having it. If the patient does not have cholangitis, if the patient is having nutritionally well preserved, and because of jaundice, he does not have any major effects on a surgery, I don't think that it should be indication itself for just stenting. The other reason why it is that once you have stented the patient, always you will have to wait for a significant period of time. And if you see, I don't know what is your personal experience or what does the data say, but we have personally felt that quite few number of patients, when you re-evaluate them after that, they fall into beds with a nodal disease. So I think to prevent that, I think there is a trend that we go on towards the early surgery, even if the bilirubin is high.
Yes.
Third thing you said about vitamin K.
Yes, sir.
3 doses IV.
We here give 3 doses. 3 to 5 doses we can go ahead with, sir.
Yes, I agree with that. What you are not wrong. I am not saying that you are wrong, but for rest of the students, the important thing is that always vitamin K is available in two forms. One is IV and IM. So it is not always IV. One thing. Second thing, vitamin K, if you are giving in any of the forms IV or IM, it can be given a maximum earliest dose of 8 hourly. It is not mandated that it has to be given OD. And this 8 hourly, once you give it after 8 hours, after 24 hours, you have to repeat the INR so as to check what Dr. Sitaram was saying. If you don't get it corrected, then that is definitely a worrying thing. So rapidest, if you have to give that, then you can give it 8 hourly vitamin K.
Yes.
Next thing was there was a discussion on antibiotics. How early, how long before the surgery?
Yes, sir. Sir, if the patient has cholangitis, then we have to continue long-term antibiotics, sir. But if there is no cholangitis, then we can go ahead with a single dose, sir.
Single dose prior to surgery,
Yes,
before
sir,
induction.
60 minutes. Yes, sir.
Yeah, that is a standard. So I think there was some discussion that jaundice you have to give pre-operative. I felt that way. I think that discussion. So therefore, I want to. Yeah, you may continue.
Yes. So after exposing the patient, we have to take the
Yeah, sorry to interrupt, but we are already at 9:56 and we have the meat of the presentation still pending. So I would request Dr. Sitaram to give us one more Saturday. And Neha, maybe you can make the rest of the presentation, because in the meantime, we can take some questions and comments from the students and faculty who are present on the issues which we have already discussed. Before that, Dr. Sitaram, on the issues which she has presented so far, any other point you would like to add? Please unmute yourself, sir.
Sorry. I'm fine. Okay. So far, it's good. Yeah.
Any student wants to ask anything on these issues so far? I can see Dr. Manas Sahu there. I can see Rajen Desai there. They would like to make any comment as faculty. Any other faculty member who is present?
May I interrupt, sir?
Yes, please, Rajen.
Yeah. I had a couple of questions. You mentioned something about vessels, arteries being involved and it being unresectable for that. When you take into consideration Appleby's procedure, proper hepatic artery involvement is not a contraindication.
Yes.
And so if you are able to check on table, you need to check involvement of the SMA. It's not just imaging based SMA involvement. It's an artery first procedure has to be used to define irresectability.
Yes.
And the other thing, nutrition is useless if it doesn't teach what has been shown. Just 2 to 3 days of nutrition will not do anything. And you always have to see worsening jaundice versus nutritional supplementation. A careful assessment has to be made of the nutritional status of the patient. And then you should take the decision whether you're going to hold on for 2 weeks to increase their nutrition. Another thing that the Japanese authors say is basically it requires 4 weeks of decompression before mitochondrial function in the liver returns to normal. And that's why they wait for 4 weeks. What's your opinion on that?
Sir, we generally...
I think we've lost the connection with Neha. In the meantime, we'll take other questions.
So we go ahead, sir. Earlier.
Neha, please repeat because we lost your voice in between.
Sorry, sir. Sir, I said that we generally don't wait for 4 weeks, sir, because then the patients progress in their disease and may become unresectable. Here we have seen it quite a few times, so we don't do that, sir. We go ahead as soon as we feel that now it is okay to take the patient.
So again, students, what Dr. Rajen Desai said is true, that the scientific evidence is that the reversal of deranged mitochondrial function of liver takes much longer after preoperative biliary drainage. So 2 things. One, the reason why we do preoperative biliary drainage before a major hepatectomy is different, because there post-hepatectomy liver failure is the commonest cause of mortality. And that is why almost all groups except some in the West would do a preoperative biliary drainage before doing a major liver resection and bring the bilirubin down to normal or at least below 3 in all cases. On the other hand, as we have already discussed, that high bilirubin alone is not an indication with most groups for pre-op biliary drainage before a pancreaticoduodenectomy. Now, in practical terms, what Neha said was right, that most groups would wait for the objective of the pre-operative biliary drainage to be achieved. So if the objective is control of cholangitis, once cholangitis is controlled, after giving a gap of about 7, 10, maximum 14 days, you can operate. If the objective was high bilirubin, then you bring it down to less than 5, which is the usual cutoff accepted by most groups if you do pre-op biliary drainage. If the objective is improvement of renal or coagulopathy dysfunction, once that's objective. So there is no fixed time limit. This again, most students, when we ask this question, they say, I will wait for 2 weeks. No, that is not the correct answer. Correct answer is it depends on what was the indication for pre-operative biliary drainage. Now, Prachin has asked the discharge criteria after Whipple. We'll discuss it later. Govind says that other than uncontrolled cholangitis, which other are absolute indications for biliary drainage? Neha.
Sir, other than acute cholangitis, biliary drainage would be again if we are if the patient needs nutritional support, sir. For that, if we have to buy time, we will have to wait, sir. If the patient has any renal problems because of the cholestasis, we'll have to, if we want to correct that, we have to wait. If the patient has coagulopathy, and we want to correct that during that time, the patient may require treatments.
I would slightly modify. See, suppose the patient's bilirubin is 5 and patient is not nutritionally fit. I don't think I will drain.
At that time it would.
So that is not an absolute indication, as Govind himself has said, is a neoadjuvant treatment for borderline resectable. Other are soft indications which you do assess from case to case basis. Coagulopathy not responding to adequate dose and adequate duration of vitamin K may be an indication, but that's not the usual scenario. Sudeep Kanungo says pre-operative diagnosed with portal cavernoma with periampullary carcinoma. What would you do? Suppose for whatever reason there is a portal cavernoma.
So there is portal cavernoma initially, and if sir, if we have the expertise, like here we are doing such surgeries, then I would like to go ahead with the surgery itself. But if it is not possible, if we don't have that much control, then maybe we can go ahead with a shunt surgery if a shuntable vein is present initially, and we can then plan a surgery again, but not waiting for a long time, sir.
Dr. Sitaram's group had earlier reported on surgery for biliary stricture with portal hypertension. Dr. Sitaram, what about PD in presence of a cavernoma?
Two situations in this. First one is extrahepatic portal venous obstruction with portal cavernoma, normal liver, and periampullary carcinoma, carcinoma head of pancreas requiring pancreaticoduodenectomy. You should go ahead with the understanding that bleeding is going to be a big issue during the operation. And you probably will not use as much energy sources for your hemostasis. You will probably rely more on conventional ligature and division. So that is one situation. The other situation is when there is unsuspected cirrhosis of the liver and portal hypertension, and you have operated on the patient. You open the patient for pancreaticoduodenectomy. I have a very nihilistic view as far as this is concerned. In my hands, patients have done very badly when there is cirrhosis, portal hypertension, and the need for pancreaticoduodenectomy. I would not do a pancreaticoduodenectomy in this situation because in my hands, the results have been uniformly bad. So I would probably do a biliary enteric bypass and a gastroenteric bypass. And if my oncologists are willing to give chemotherapy for this patient, I would go ahead with chemotherapy. So the two situations are different. In the first, the liver is good, so the problem of liver dysfunction doesn't really happen, and the problem is more of technical bleeding is a problem because of technique. So that is a different issue. The other issue is one of liver dysfunction, cirrhosis, portal hypertension. Thank you.
So again, for the exam, the answer, appropriate or diplomatic answer would be, depends on the patient's overall nutritional, general comorbidity condition, the risk of anesthesia. It depends on the expertise and experience of the center which is going to do the procedure. It depends on the stage or the expected outcome prognosis of the disease. Suppose it is a large mass in the head of the pancreas with some nodes enlarged versus a very small periampullary tumor which is easily eminently resectable. So these are the factors which you take into account. Again, there would not be a correct yes or no. You will have to deal with each case on a case-to-case basis, and that is what we expect you to say in the exam, and that is what we expect you to do also in your clinical practice. There is another question from Sudeep again, that what are the targets to be achieved when you are doing a pre-operative nutritional assessment? So what is the minimum nutritional status which you would accept for a PD? I think that would be the last, and then we will close.
Yes, sir. Sir, the minimum nutritional status would be, again, I would like to go ahead with a clinical assessment. The patient is able to walk 2 flights of stairs. Patient is doing good spirometry, has a METs of more than 4, is able to, has a good breath holding time, and albumin levels are more than 3 milligram per deciliter. If I'm going ahead with this, if the patient has a good weight gain during this time, maintaining a BMI which is increased to more than around 19 or 20, then I would say that patient is good enough to be taken for surgery.
I would also add no pedal edema, because if
Yes,
there is
no pedal.
clinical pedal edema present, that's a indicator of a poor nutritional status, and of course hemoglobin level you will take into account. So I think we will stop this because we've already crossed 10. Thank you very much, Dr. Sitaram, and I would request you to give us 1 more hour on any other Saturday so that we can complete the operative and the complications part.
Sure, at your convenience. I'm available.
So Neha, please let Dr. Anand know when you can
Yes,
present the remaining part, and then
okay,
he will
sir.
schedule and we will request Dr. Sitaram. Thank you,
Okay,
sir.
sir.
Thank you very much. And we again have a very good attendance today. More than 30 students have joined, I think because of your name and presence being there. Thank you very much.
Thank you. Thank you. Thank you.
Okay, thank you, Neha. Thank you.
Thank you, sir.
We will close the session. Thanks, Avinash.